నాన్ ఇన్వేజివ్ ఐసీయూ అనేంటి హెడ్డింగ్ అన్నట్టుగా పెట్టారు మెసేజ్.
ఇప్పుడు చెప్తారు కదా వాట్ ఇస్ నాన్ ఇన్వేజివ్.
నాన్ ఇన్వేజివ్ ఐసీయూ అంటే ఇట్స్ నాట్ ఓన్లీ వెంటిలేషన్, మెనీ థింగ్స్ షుడ్ బి నాన్ ఇన్వేజివ్.
నాన్ ఇన్వేజివ్ వెంటిలేషన్
అంటే బేసికల్లీ విల్ సీ సార్, ఇంకా చాలా ఉంది నాన్ ఇన్వేజివ్ దీంట్లో. మనం రియల్ గా ఇంప్లిమెంట్ చేయాలి అంటే. సో మేడం గుడ్ మార్నింగ్ మేడం. లక్ష్మీరాణి మేడం
శ్రీనివాస్. మార్నింగ్ శ్రీనివాస్. ఏదో డిస్టెన్స్ ఎడ్యుకేషన్ లాగా ఐసీయూ కూడా ఏదో చెప్తున్నట్టున్నావు అనుకుంటున్నా. అందుకే ఫస్ట్ డేవిడ్ ఏంటి నాన్ ఇన్వేసివ్ ఐసీయూ అని పెట్టాడు, టైటిల్ ఏమన్నా రాంగ్ పెట్టడా అని నేనే కదా ఫస్ట్ పెట్టాను నాన్ ఇన్వేసివ్ ఐసీయూ అని.
అంటే వీఆర్ మూవింగ్ టువర్డ్స్ దట్ మేడం. చూద్దాం.
ఓకే గుడ్.
ఓకే మేడం స్టార్ట్ చేద్దామా?
ఓకే మేడం గుడ్ మార్నింగ్.
ఓకే రైట్.
Yeah, shall we start? Good morning all of you. Today there are so many doubts and dilemma about what is non-invasive actually. Dr. Dekna Srinivas, head of the Department of Critical Care, SLG Hospital, Hyderabad, is going to enlighten and clear all your doubts of non-invasive ICU. Dr. Srinivas, please start presentation.
Thank you, sir, and good morning all. Basically, anytime we have a topic, actually we get a lot of questions, queries after the topic. But this is one of the topic which created more enthusiasm all. And basically, we are now. Previously, we used to be a very deeply invasive thing. Initially, non-invasive to the deeply invasive, and now presently we are in a minimally invasive thing, because we want to go to the non-invasive and in a better way. We have to, the goal of the patient has to be the best treatment in a non-invasive method. How are we going towards that? Yes, we are going towards that. I think we need to have a more knowledge and more depth into this, and gadgets showing more outcome benefits. So let's move to this. This is we all see in our ICU. So non-invasive ventilation has come and it has improved. Anna, నేను చెప్తా అన్న slides move చేసేటప్పుడు. So this is one of the thing like non-invasive intubation, so NIV, which decreases significantly the invasive ventilation and improve the outcomes of the patients. Next slide, please, sir. Let's go with a scenario case presentation. A 38-year-old male with RTA. Patient was unrestrained, no seat belt, loss of consciousness at scene on arrival. Pulse rate is 126, BP is 90/50, respiratory rate is 14. GCS is only 6, so immediately intubated the patient. Next slide. Here, non-invasive doesn't work, so we need to intubate this patient. Next slide, sir. Yes, sir. Sir, so we have intubated the patient. So any patient, Anna, just wait, Anna. So how do we, most of the times, suppose if in the case of a difficult intubation, we go for identification, either capnography or capnography is mandatory nowadays in intubation in the CPR situations to identify the placement of endotracheal tube. And sometimes bronchoscopy also needs to, we can use for identification, not for the therapeutic procedure, for the identification of this one. And most of the times we use the mandatory is the ETCO2. Can we do some other things like ultrasound? Because in ETCO2, we need to have an ETCO2. Most of the ER monitors may not have an ETCO2, and ETCO2 is also very expensive. Can we do something without a can we do something on non-invasively? Sir, please show, sir. So this is one of the video where we can differentiate the tracheal from the esophageal intubation. You all know, you all practice it. Place on the suprasternal notch and see to identify trachea, thyroid, and esophagus. Now, basically, again, see, this is a esophageal intubation. Okay. And this one is a tracheal intubation, where okay. Next slide. Next slide, please. Yeah. So if you see the capnography versus ultrasound, next slide, sir. So here, ultrasound has a sensitivity of 96.8% and specificity of 100%, and positive predictive value of 100% and negative predictive value of 62.5% when compared with the waveform capnography. So here is as good as capnography, and capnography took only around approximately 9 seconds for the confirmation of ET2 placement, and upper airway ultrasound took 12 seconds. That is which is a difference of 3 seconds, and which was highly significant in identifying the tube placement. So this delay of other than 3 seconds of delay with identifications, the ultrasound is as good as ETCO2 in a patient. But in a situation of CPR, the other indications, the other information we can get from during the CPR is the quality of CPR can be identified with the help of ETCO2. But here the placement of the tube can be confirmed with the help of ultrasound. Next slide, sir. This patient CT brain, we are able to see SDH in the bifrontal and left temporal and right parietal contusions are there. The midline shift. So we all know that when there is such type of contusions with low GCS, along with the blood, increased CSF and brain tissue, there is also extensive mass lesions are there. That is around hemorrhages or any tumors or anything. So this can cause increased intracranial pressure. So ICP less than normal is 3 to 15, less than 20 is generally accepted. So it is defined as CPP is defined as mean arterial pressure minus intracranial pressure. So the target of cerebral perfusion pressure is 50 to 60. So this can be maintained because we need a cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. Intracranial pressure can be monitored only with the help of a catheter placed in the ventricle. So here also, let's see why we need to measure the intracranial pressure. If you see in the x-axis, intracranial volume, pressure on the y-axis, the intracranial volume is increasing. So initial delta V1, if you see V1, for a significant increase in the volume, the pressure is not increasing, only delta P1. The pressure increase is very minimal. As the pressure is the pressure is increasing. Here, if you do V2, even the similar increase of volume, there is a very high increase in the pressure. So when the curve, where the curve is there, that is more important. The volume, similar increase of volume at the lower end V1, the pressure increase is less, and at the V2, the pressure increase is more. So this also is along with us. This explains that why is this happening? Because there is a high compliance at the lower level and the minimal compliance at the higher level, as because there is a collapse of the cerebrovascular microvasculature occurs and the routine mechanism is lost. So usually up to around 50 to 150, the cerebral regulation is maintained, cerebral perfusion pressure is maintained. But in a patient with a stroke or a large bleeds, or with a patient with a large bleeds, or the patient with a hematoma, these patients, when the auto regulation is lost, then automatically their pressure also will increase. So this slide shows about the invasive monitoring, like intracranial pressure monitoring, SJVO2, cerebral microdialysis, and PBTO2. I just have a look onto this. So what we do here, we put the catheter in the various places, like We can put on a ventricles, subdural bolts, subarachnoid spaces, intraparenchymal, all these things we will be putting a brain monitoring. Next slide, sir. SJVO2 is again so if you go into this intraventricular catheters, there is an advantage that if the pressure is more, we can remove the fluid also, so that the pressure also is decreased. So that it both has a diagnostic and therapeutic purpose. HAVO2 is similarly how we put a catheter, central venous catheter. So if you cannulate towards the upside, then it goes up to the jugular bulb. There is a resistance at the jugular bulb level. So this can be monitored, and we can monitor the SJVO2. Next slide, sir. So SJVO2 is, in general, it is around 50 to 75 is a normal, because SJVO2 says that like SCVO2, the SJVO2 is the brain oxygen utilization. Out of 100%, it will be utilizing around 25 to 45% is utilized. So suppose if it is more than 75, we can say that the supply is more, uptake is low. So supply more because of cerebral vasodilatation, hypercapnia, hypertension. A decreased uptake is because of sedation, coma, infarction, brain death, hypothermia. SJVO2 less than 50 means increased uptake, decreased supply. Increased uptake is possibly because of fever, agitation, pain, seizure, cerebral, and decreased supply is because of the vascular constriction, anemia, hypocapnia, hypotension, and vascular. Next slide. So cerebral microdialysis is again a catheter into the brain parenchyma from the right frontal lobe, and measures glucose and lactate. Increased lactate leads to increased energy substrate depletion and anaerobic metabolism, similar to the what we measure in the arterial lactate. Similarly, they measure the fluid from this, and this is a catheter they put in the EVD and microdialysis catheter. So if it is more lactate, that says that there is an anaerobic metabolism going on in the brain. Next slide. So here there will be a different PbTO2 is a tissue oxygen they are monitoring at the parenchymal level. So how do they monitor is they put a catheter into the parenchyma and then measure. Normal is less than 15, normal is about 20. Less than 15 is associated with cerebral ischemia and pure neurologic outcome, because suppose if the patient, our patient, has a bilateral frontal contusions. So if you put at the parietal or in the temporal region where there is no contusion, the PbTO2 might be normal. So here this also has a validation is a problem. So when there is an injury, if you measure there, the cells which might have died and PbTO2 is very low, might be very low. So but the other parenchyma might be normal. So it's very difficult to interpret this patient. Next slide. Yes, sir. So PbTO2 probe. Next slide. So ICP monitoring. So ICP monitoring, in catheter monitoring, there was a lot of studies and a lot of debates. Okay. So they said that the ICP monitoring, such an invasive and high chances of infections, and patients land with meningitis, meningoencephalitis, and a lot of other issues. So they have divided into, so overall there is no difference, but they have divided the studies mortality before 2007 and after 2007, because the quality of improvement increased. The after 2007 ICP monitored group has a decreased mortality, and before 2007 there is no decrease in the mortality. There is no difference in the mortality. Next slide. So in this ICP and monitoring and meta-analysis, they found that there is a decreased mortality in the group. But most of the studies were all observational studies, not a randomized studies. When compared with in a randomized studies, there is no difference. When it is in an observational studies, there is a significant improvement in the ICP. In the ICP monitor group, there is a decreased monitor death. So if you see invasive monitorings, we have discussed about ICP monitoring. There is no clear-cut randomized studies mentioning that monitoring of ICP decreases mortality. SJVO2, it tells only about the global demand of the patient, but it doesn't say the local. Suppose if this patient, if the patient SJVO2 is 60, that doesn't mean that this patient doesn't have a low GACS or low or a poor outcomes, because HJV-O2 is normal, but patient can be bad or patient can be normal. So cerebral microdialysis, it tells only about the lactate present, but it cannot tell. Then how do you resuscitate the patient if the lactate is low? So it also is not a well established practice and more invasive. PbTO2 tells us only about the oxygen at that level. So if you measure on the normal parenchyma, it may show low. So in this, there are a lot of issues with these 4 monitoring systems, which none of the monitor will tell us accurately which is a better. And there is no strong evidence, so we are also not monitoring the ICU. But there can be a lot of complications associated with invasive monitoring. So let's see, do we have any non-invasive ICP monitoring tools? Next slide, sir. So we have CT scan, MRI brain, TCD, ultrasound, and nurse. Next slide, sir. So anatomical changes associated with elevation of ICP that can be detected using CT scan and MRI. Mass occupying lesions can cause compression of ventricles and midline shift and enlarged ventricles. Cerebral edema, loss of differentiation of gray and white matter junctions. MRI-based techniques to estimate ICP by assessing net intracranial blood and CSF flow was able to differentiate patients with normal or raised ICP. But every time for a patient who is having a raised ICP, every time taking the patient to CT scan and MRI and doing this is very cumbersome, and it is also not cost effective. And actually, we don't know the exact ICP of this patient when we are doing a CT scan or MRI. If you know the ICP, then daily we can do a CT scan for this patient. It will tell us if there is any pressure is there or not, but it doesn't tell us the value. So if you see the TCD recently we have done in a workshop. So most of these things we have discussed in the workshop, recently reflect workshop. So TCD changes in cerebral blood flow, subarachnoid hemorrhage associated vasospasm. So TCD derived measurements of flow velocity in the middle cerebral artery, arterial blood pressure, and pulsatility index. A TCD-based assessment of cerebral blood flow and autoregulation has been more successful than TCD-based ICP estimation. So basically, it tells more about the cerebral blood flow and the vasospasms than about the value of the ICP and ICP estimations. So we recently demonstrated, the Satish sir and his team demonstrated recently in the workshop. When an optic nerve exits the intracranial space into the orbit, the subarachnoid space surrounding the nerve is continuous with the intracranial subarachnoid space. So elevation in ICP can transmit through CSF in subarachnoid space, leading dilatation of the optic nerve sheath. So where we are measuring the intracranial pressure, that is into the subarachnoid, that is into the ventricles, frontal horn of the ventricles, the same pressure what we are measuring in the ICP is reflected into the optic nerve sheath. So we need to measure the optic nerve sheath diameter. So what's the evidence? Next slide, sir. So optic nerve diameter, we also have a video also. So this is a measurement of optic nerve. Yeah, next slide, sir. So the various, so this is one of the thing where we can immediately cannot identify the patient is having a raised ICP or not, because there is a wide range in the optic nerve diameter. So there is a wide range is there. So the only trends will tell us the optic nerve diameter, because most of the some of the studies said that more than 5 millimeters it is mentioned as a raised ICP, but sometimes it can be normal. So some of them it shows that more than 5.5 it is raised ICP, but some it can be normal. So the trend in the increase in the diameter is more useful than the measurement in the single time. Next slide, sir. So the various parameters like ICH, trauma, SAH, they have post-anoxic, they measure the ICP, intracranial pressure, and the diameter of the ONSD. And here we have to take, whenever we are measuring, we have to take at least 2 to 3 parameters, and it has to be measured on the bilaterally. Both the eyes we have to measure, and 2 to 3 parameters, and we have to average it. Next slides. Please look into the ocular ultrasound examination. So it is just an ultrasound examination I am seeing, showing you how to measure it. So that black one down is the optic nerve sheath. So which can be measured, because he is now showing how to accurately measure it, because any way if you put it can come, but only the lens should not come in the way of this measurement. Otherwise it will have a false readings and issues. So next slide, sir. Next slide, sir. Sir, next slide. Yeah. So optic nerve sheath diameter with intracranial pressure monitoring. So we have few data. Next slide, sir. So here, when the ICP is, so ONSD can tell whether ICP is less than 20 or more than 20. As we discussed, 5 to 15 is normal, and this more than 20, it is more in ICP is very high. So this usually here the diameter mentioned was 6.6 plus or minus 0.5, and a 5.89 less than 20 is 5.89 less, but it is the diameters are very high. Next slide, sir. And Satish sir also has a small observation study on this ONSD. He can share it later. His experience also. I think he has monitored around 50 patients. So in a healthy adult, ultrasound range from 3.68 to 5.4 millimeters. So as I mentioned, there is a wide range in the diameter. An ICP of more than 20, an optimal cutoff value of ONSD was found to be more than 5 millimeters. Midline shift detected by CT corresponds with the optimal cutoff value of 5.3 mm ONSD with a sensitivity of 70 and specificity of 74%. Meta-analysis on ONSD ultrasound compared with findings of increased ICP on CT imaging, sensitivity of 95% and specificity of 92.3%. The next slide. So strong correlation between ONSD and ICP measurements in patients with traumatic brain injury, and statistically significant correlation between ONSD and ICP before and after treatment with mannitol. Median values of ICP and ONSD were 35 mmHg and 6.3 mm respectively. These rates decreased significantly after mannitol infusion to 25 mmHg and 5.7 mm respectively. Next slide. So we have, along with the ONSD, we also have already we discussed about CT, TCD, ultrasound. Now we about NIRS. So this is a near infrared spectroscopy, a non-invasive tool for measuring oxygenation in the muscle and other tissues along the thenar eminence is the most widely tested site. So several studies reported an association with lower thenar tissue oxygen saturation and poor outcomes, especially during sepsis. So in conjunction with vascular occlusion test, NIRS allows analysis of changes in STVO2 during a brief ischemic challenge, providing dynamic parameters of tissue oxygen extraction and microvascular reactivity. Next slide. Yeah. So STO2 and tissue hemoglobin index were calculated at the baseline. Okay. So here, if you see, next slide. So if you see here, the tissue oxygen will come down. So this tissue oxygen, where they are measuring at the level of the capillaries. So that capillaries to venules they are measuring. So where do they come? When I go into the microcirculation, I will explain you. So they are measuring at the microcirculation level. That is at the less than 100 micrometers, and they are mostly at the capillary and at the venules. So these are measured. So here, when you occlude and measure the tissue oxygen, it goes down, and when it is, and when this occlusion is released, it goes into the hyperemic phase and it comes to the baseline. So which tells that the about the so what it tells is the ST slope down is generally calculated by the regression line at the first part of the ST decay after occlusion, providing an index of tissue oxygen extraction ratio. So this is the desaturation slope may vary during the ischemic phase of the VOT, becoming more steep or less steep before reaching the 40% STO2 threshold. So there are two slopes in this. Slope down one and slope 2 is there. So delta slope down was then calculated as the difference between the last and first part of the desaturation slope. So that positive value indicated flattening in the second part of the slope. So STO2 upstroke percentage, that is means the curve of the hyperemic response were calculated as the indices is also microvascular reactivity. So there is a hyperemic means there is a tissue perfusion and its reactivity is good. So we can discuss, I think these are the things more non-invasive. We are not using it. Probably we can start using it so that we know better non-invasively. Yeah, next slide, sir. So this is about the, as I mentioned, the monitor showing the both the cerebral and renal STVO2. So here it is the curve showing STVO2, how it comes from the 70, and once fluid resuscitation, sedation, paralysis started, so the demand decreased and started increasing the STVO2. Next slide. So we also need to do an EEG in the ICU. This is also, so patient is having any seizures. So it's very difficult to monitor this patient. So aneurysmal SAH has 20 to 25% seizures. Intraparenchymal hemorrhage is 21 to 28%. Moderate to severe TBI 20 to 30%. CNS infection approximately 30%. Septic encephalopathy, post-cardiac arrest, we see very high, approximately 60%. Acute ischemic stroke 20 to 30%. So EEG has to be monitored. And suppose if you have a suspicion of a seizure, or if you see the subclinical seizure on monitoring, so continuous monitoring has to be done, because again there will be a more brain damage into it. So next slide, sir. This patient is having hypotension, so post intubation, ultrasound thorax done, so non-invasively again, no pneumothorax, no hemothorax, cardiac function is normal. Fracture of both shafts of femur, okay, and this also can be done along with the ultrasound, and fluid resuscitation given still having hypotension. Next slide. So we obviously go for invasive blood pressure monitoring. They try to see whether there is any difference between the non-invasive and invasive blood pressure monitoring. Invasive blood pressure monitoring is good, and there is no compromise in this. We have to go for an invasive line as soon as possible when the patient is having a hypotension. Next slide. So invasive monitoring, many invasive monitoring are, hemodynamic, like CEG. Now we are rarely using it. We are putting the center line, but we are using this line for giving vasopressors and fluid can be given in these patients. And the PA catheter previously we used, but now there is no role in the ICU, so we are not using it. There's more harm than a better outcome. And cardiac output monitoring, we are doing with various monitoring systems, whether a PA or non-PA associated cardiac output monitoring. And specifically, non-invasive cardiac output monitors has not proven to be much benefit. And we use systolic pressure variation, pulse pressure variation, stroke volume variation, SVC compressibility, and transesophageal echocardiography. So these are all invasive monitoring for monitoring the hemodynamics for a fluid resuscitation for our patients. Next slide. So not going into the depth of that one, but we also have a non-invasive monitoring systems like 2D echo. So recently showed how to calculate the cardiac output of this patient. Even though cardiac output is a static measure, but the more important is velocity time integral, like David has shown very clearly during our workshop, and he has also shown IVC measurements during the various phases and how to interpret it. So these, and also VTI. VTI is now the one of the best parameter for the fluid resuscitation. And there is also some of the parameters like bioimpedance and bioreactance, partial CO2 rebreathing, pulse wave, transit time. I think I'm not concentrating on these three things: bioimpedance, the partial CO2 rebreathing, and pulse wave transit time. I think hope we'll have a discussion next time. Okay, these are all the IVC assessment. Sir, please show. And Dr. David has shown very well in a patient. And we all routinely use the IVC in our patients for an assessment. Sir, video పెద్ద ఉన్నట్టుంది, జస్ట్ విల్ skip sir this one. Well, అందరూ తెలుసు కదా. David sir. We'll go to the next slide, sir, because everybody knows.
Okay.
Next slide, sir. So fluid resuscitation is done, and the peripheries are cold. Previous slide. Yes, the peripheries are cold. Pulse oximeter unable to sense well. So I have few tissue parameters like SCVO2. Now we are not using it. Lactate and base deficit can be used. Lactate is one of the best marker. Do you have non-invasive monitoring tools for the tissue perfusion? Next slide. So microcirculation is less than 100 micrometers diameter, which comprises of arterioles, capillaries, and venules. Okay, it includes endothelial cells, smooth muscle cells, red blood cells, leukocytes, platelets. Next slide. So the oxygen demand and extraction by different tissue cells is dynamic and complete process. So the process is mainly regulated on three levels. One is systemic distribution. So the systemic distribution we measure like invasive blood pressure or non-invasive blood pressure. Microcirculation is measured either with a lactate, base deficit, or SCDO2. Versus, can we do something, check microcirculation directly, non-invasive. Mitochondrial extraction, I think this we cannot measure it. Next slide. So systemic distribution, as I mentioned, cardiac pump, aorta, and large arteries. Next slide. So here we have come to the microcirculation. Here is the first R, red one. First red one is aorta. Then the arteries, major arteries. Then comes the arterioles. Then comes the capillaries. Then venules, veins, and vena cava. So here mean arterial pressure is the larger arteries. When it comes into the microcirculation, here this dotted line, here it comes as a microcirculation at so even if the patient pressure has around 120 or 140 or 200, at the microcirculation level, the measurement is very, very less. The drop can be up to around, usually around 5 to 20, and approximately usually up to 20. So the 30 to 20 to 30 will be there at the pressure. So at that level, we are measuring the microcirculation. Next slide. Yeah. So physiological shunt occurs in a situation where oxygen supply is high or demand is high. So hyperdynamic flow can occur in a well-perfused vessels. These hyperdynamic flows too fast through the capillaries and therefore does not have enough time for an adequate oxygen exchange. So next slide, sir. So how do we do? We know that OPS imaging technology, video microscope able to create high contrast images of blood in the microcirculation using reflected light. So blood vessels of microcirculation can be visualized by OPS imaging. SDF imaging is based on the emission of the ring of green light with a wavelength of 530 nanometers by light diodes. Next slide. It is reflected by the tissues observed by hemoglobin, which allows the visualization of hemoglobin saturated erythrocytes. So these can be made with a handheld microscopic camera at the tissue level, which is measured at the various levels of the microcirculation. So current guidelines says at least 3 to 5 microcirculatory sites should be measured, and minimal recording time of 20 seconds per site. So in healthy individuals, next slide, sir. So microcirculation can be measured at multiple levels: sublingual mucosa, ocular conjunctiva, jejunal mucosa, rectal mucosa. So usually we see at the sublingual mucosa. So this is a model where we all have seen a handheld meter. This next slide, sir. This is the first one is a homogeneous microcirculatory distribution. See here, we see homogeneous distribution of the microcirculation. Here heterogeneous circulation, here it is there. See here, there's all the breaks in the circulation is seen with the handheld microscope. So this, when the good thing is, we also, while fluid resuscitation, the heterogeneous microcirculation can partially revert into homogeneous circulation, and there is a fluid resuscitation based on this microcirculation is present, and usually these equipments are not available or not used, basically not is available but not used widely, so that we don't have much experience. Hope we get in the future this type of equipment and we use it more widely, so that even we don't need much of a lactate also. Just we can see the put a microscope under tongue and then under the mucosa, and then we can see whether fluid can be given or not. Okay, we are not going into the complete evidence. Next slide, sir. So difficulty in weaning. So we used to have a weaning difficulty in a patient. I think Mohan sir was also there in Nizam when Mohan sir and myself was, sir, Kuncham. When Mohan sir and myself was there, so in Nizam's, we have seen the patient having one of the patient difficulty in weaning. So we got a lot of experts, and he was one of the minister. And this is in 2002, Telangana state or somewhere minister at the time, Andhra Pradesh. We don't know which, some minister got intubated in the Nizams, and he was in our ICU, and difficulty in weaning. So they said the diaphragm is not functioning. So then we thought, how do we test the diaphragm? So then they bought some experts from somewhere, and Bombay or somewhere, and we took this patient to fluoroscopy, cath lab, and so we saw the diaphragmatic function. So we found that there is a diaphragmatic dysfunction, and they thought they will do some procedure, and there's a thing. But again, next day after a week, we want to see slowly we are able to put him on a pressure support ventilation. We again wanted to measure his diaphragmatic dysfunction, what is the function improved or not. Then we again contacted him. He did not respond. So every time going to the fluoro is a very difficult task. I think we have a very simple non-invasive ultrasound measurement where we all can see now. Even hourly we can monitor, or half an hour also we can monitor. Sir, please place. This is again shown by, I think, in our workshop, diaphragmatic dysfunction. So here we are able to see the liver, diaphragm. సార్ దీనికి ఇది కూడా ఉంటుంది సార్, సౌండ్ ఉంటుంది సార్, ఒకసారి చూడండి, చెక్ చేయండి మీ ల్యాప్టాప్లో
సౌండ్ కంట్రోల్ లేదు సార్.
ఓకే సార్. సార్ వీడియో ప్లే అవుతుందా?
యా నౌ యు ఎక్స్ప్లెయిన్.
Yes sir. So he has putting now into the anterior part of the he's taking the liver as an angle, and he's measuring the diameter. See, he's putting a liver as a through that, so that is he's showing the liver, that is a diaphragm. So he's seeing a good movement of the diaphragm. He has put in a M mode, and is the lower one is the diaphragmatic movement. So what he does is he will now freeze it, and he will measure the diaphragmatic movement when it is. So it cannot be just measured. We need to look into the what is the during the inspiration and expiration ratio has to be mentioned. Then usually less than 10 millimeters, that is less than 1 centimeter, is very poor, and usually normal is around 2 point. In a we can be winnable if it is more than 2.5. It is normally approximately around 5 millimeters, 5 centimeters or something in a normally deep inspiration. So less than 1 centimeter is poor, and 2.5 it is better. And I think we can have a repeatability of this patient. So this patient, later we have done a tracheostomy, and hemodynamically stable. We have done tracheostomy, and he's off a ventilator. We could wean this patient, and he is on thermovent. We shifted this patient to this one, and then room, and he got discharged to a rehab center. So this is the story of the patient, and these are the non-invasive things. I think there is a long way for us to look into a non-invasive, and so that we can have a repeatable. Thank you. Any questions?
No.
Thank you, sir. Open for discussion.
Yeah. Thanks, Anna.
The few of the things I did not discuss. Hope we'll try to look into some of the non-invasive monitorings into the next class when my turn comes. Thank you, sir.
Yeah, thank you, Anna. I explained everything about non-invasive procedures in the ICU, which is compared with invasive procedures, and what is the benefits out of non-invasive to prevent the infection, and lot of money to the patient, and also is equally correlate with non-invasive and invasive. There is no much significant difference unless patient is very critically ill. So sometimes, many times, you can avoid invasive procedures and complications if you carefully monitor the patient in a non-invasive, with having non-invasive gadgets in your ICU. Thank you for your nice presentation. Any questions? Hello?
Hello.
Madam.
Srinivas, nice class. Only thing is, to use all these, everyone needs to be trained, and sonosite or ultrasound machine should be available readily in your ICU. Then only all this can be done. Sometimes, I mean, like, because everybody need to learn all this, how to monitor, there'll be subjective variations, right? So till then, until otherwise, people have learned, and maybe to accept all this, one need to be having a certificate that we can do properly అనేది ఉంటే కానీ people won't trust. The other test ఏంటంటే objective, we have fixed ఇది చేసాము, you have a proof, you have numbers. But for this one, like, everything need to be subject, I mean, have to be trained, and ఇది కూడా proof చూపించాలంటే you have to have a printout. This is what we got అనేది proof చూపించగలమా దీంట్లో?
మేడం
ఇప్పుడు అల్ట్రాసౌండ్ యూజ్ చేసిన దాంట్లో we can say we have seen this, and on the screen you see, but like, if you are in like కొంచెం ట్రబుల్ మేకర్స్ ఉన్న దగ్గర, కొంచెం లిటిగేషన్ అనుకున్న దగ్గర, ఆ ప్రూఫ్ మనం ప్రొవైడ్ చేయాలంటే యూ హ్యావ్ టు హ్యావ్ లైక్ ఆ బిగ్ అల్ట్రాసౌండ్ మెషిన్ లో వాళ్ళు కనుక ఎలాగైతే పిక్చర్స్ తీసి ఇస్తారో మనకి రిపోర్ట్ లో
ఇస్తున్నారు కదా మేడం.
మేడం
అల్ట్రాసౌండ్ దే ఆర్ గివింగ్ నో.
అదే అలాగే ఇవ్వగలగాలి మరి. ఐసీయూలో అంత చేయగలిగితే we can make it like this is equally effective అని చెప్పగలము. ప్రూఫ్ కూడా చూపించాలి అంటున్నా.
మేడం అపోలోలో we had the hospital has given a machine to us, ultrasound dedicated machine to ICU. They asked us where is the revenue after the end of the 1 month. So మనం ఏం చూపించలేకపోయినాం. So what we have done is we have prepared a format ప్రిపేర్ చేసి IVC measurements, అప్పుడు మనం చూసింది ఓన్లీ ఐవీసీ మెజర్మెంట్స్. సో ఆ ఐవీసీ మెజర్మెంట్స్ కి దిస్ ఆల్మోస్ట్ 10 years బ్యాక్. సో మనం ఒకటి చూసి దీన్ని తర్వాత క్విక్ అసెస్మెంట్ ఆఫ్ కార్డియాక్, అది ఎట్లాగో ఫార్మాట్ ఉంటుంది. సో వీటికి మినిమం ఏదో 500 or 600 చార్జ్ చేసి we used to do for every patient, we used to do it, and we take a printout and we sign it out. So as you mentioned, there should be some validity, అంటే మనం ఎవరు పడితే వాళ్ళు సైన్ చేయకుండా. So that's the reason why I think the critical care దాంట్లోనే they are including this ultrasound also. I think DNB లో include చేశారు, DRNB లో. I think they mandatory for even they are trying to include in IDCCM also, so that we are certified means that we are having a certificate and you are trained in ultrasound అని. So we can certify it and we can do it, madam. Most important madam నాకు అనిపించేది ఏంటంటే most of the ICUs, we all are working in corporate, most of the ICUs have ultrasound machine. Most of them don't have a time to do it. మనకు పర్ఫెక్ట్ అయిపోతే 5-10 minutes లో అయిపోతుంది. కాకపోతే ఆ ట్రైనింగ్ చేయాలి అంటే ఈ ఇంటెన్సివ్స్ ఆర్ లెస్ అండ్ వర్క్ ఈజ్ మోర్. దట్ ఈస్ హ్యాంపరింగ్ మోస్ట్ ఆఫ్ ద. అది మేడం, ప్లీజ్ యాడ్ మేడం.
Yeah. That's what, like, as you said, if people have certificate, like at least ICU procedures key for this procedure, the competencies are checked and certified by the head of the department, or by maybe certified by radiologists in our hospitals, like they are doing right way and this is valid అనేది ఒకటి అంటూ ఉంటే మనం చేస్తే కూడా వీ కెన్ చార్జ్ ఫర్ దాట్. రైట్ నౌ సోనసైట్ ఉన్న ప్రొసీజర్స్ చేసిన ఎక్కడ కోడ్ ఫర్ దాట్ లేదు అనేసి మాకు ఛార్జ్ కూడా అవ్వట్లేదు. అల్ట్రాసౌండ్ యూజ్ చేసిన వాటికి కూడా ఎక్స్ట్రా ఛార్జ్ పడట్లేదు. అండ్ దే ఆర్ సేయింగ్ ఇంత పెట్టి వి బాట్ దిస్, వేర్ ఈస్ ద ఇన్కమ్ ఫ్రమ్ దాట్ అని అడుగుతున్నారు. And there's no code to charge for that.
మేడం మీరు రిపోర్ట్ జనరేట్ చేయకపోతే ఇన్సూరెన్స్ పేషెంట్స్ అండ్ కార్పొరేట్స్ విల్ నాట్ పే. క్యాష్ పేషెంట్స్ చార్జ్ చేయొచ్చు కానీ ఇన్సూరెన్స్ అండ్ కార్పొరేట్స్ విల్ నాట్ పే మేడం. They have to see the report.
Yeah, that's why I'm saying మనకి ప్రూఫ్ బిగ్ మెషిన్ లో వాళ్ళు కనుక పిక్చర్స్ తీసి ఇచ్చినట్టు అది ప్రూఫ్ పెట్టాలి, రిపోర్ట్ ఉండాలి, అయితే కానీ ఇట్స్ నాట్ వ్యాలిడ్ కదా అంటున్నాను.
Actually, we don't have any. We need not showing the income for ultrasound. We have a ultrasound, but we need not show any income for that.
అన్న నువ్వు డాన్ అన్న,
Huh?
నువ్వు డాన్.
జకినా సార్, హలో సార్, గుడ్ మార్నింగ్. హలో జకినా సార్,
చెప్పండి
సార్. అదే థింగ్ ఈజ్, అంటే ప్రూఫ్ కంటే వీ కెన్ సేవ్ ద వీడియోస్ అండ్ క్లిప్స్ ఆన్ అల్ట్రాసౌండ్ ఫస్ట్ థింగ్. సో అది మనం కంప్యూటర్ లో కూడా ట్రాన్స్ఫర్ చేసుకోవచ్చు బై ట్రాన్స్ఫరింగ్ ఇట్ టు పెన్ డ్రైవ్. సోనోసైట్ హ్యావ్ దట్ ఆప్షన్. రెండోది ఏంటంటే ఇన్కమ్ వరకు వస్తే సేమ్ థింగ్. దాన్ని ఏమంటారు, వ్యాలిడిటీ ఇట్ కాంట్ బి కంపేరబుల్ టు ఎనీ రేడియాలజిస్ట్ ఆర్ దిస్ థింగ్ వాట్ యూ సే యాజ్ కార్డియాలజిస్ట్. ఇప్పుడు ఏమొస్తుందంటే ఆన్ ద బెడ్ సైడ్ అల్ట్రాసౌండ్ అని చెప్పి ఇఫ్ యూ గో ఫర్ ద జేసీఏ థింగ్, అంటే జేసీఏ ఇన్స్పెక్షన్ కానీ అయితే దే ఆస్క్ ఫర్ ద వ్యాలిడిటీ ద సేమ్ థింగ్. బట్ ఏంటంటే ఇప్పుడు పీడీసీసీ వాళ్ళు చేసిన కార్డియాలజీ ఆ ఎకోస్ కూడా వ్యాలిడ్ కావు. What they do is they record the videos and they say that they confirm with the consultant before they give the report, and their validity comes there. So alage manni kuda probably win focus is oka konచెం I mean standard training program. So aa certificate unna evaraina consultants undetappudu we save the videos and we should have a recheck with this, and we should say that this is signed, as you said, like oka form tisi sign cheskoni this person is signing by checking these videos and cheppi we can increase the validity.
See, as you mentioned, ఇప్పుడు మన హెడ్ ఆఫ్ ద క్రిటికల్ కేర్ డిపార్ట్మెంట్ కానీ హెడ్ ఆఫ్ ద రేడియాలజిస్ట్ కానీ ఇస్తే వ్యాలిడిటీ కొంచెం తక్కువే ఉంటుంది. బట్ సొసైటీస్ హ్యాస్ టు గివ్. వెన్ సొసైటీస్ గివ్ అక్రిడేషన్ ఆటోమేటికలీ ఇట్ ఈస్ వ్యాలిడ్.
అంటే అది ఒక బ్రిడ్జ్ వచ్చేస్తుంది సార్. అంటే ఇన్ ద సెన్స్ లైక్ రేడియాలజిస్ట్ ని ఓవర్కమ్ చేసేంత మనకి ఇవ్వరు. సో ఆబ్వియస్లీ దేర్ విల్ బి అ డిఫరెన్స్.
These are all the dynamic parameters where you are resuscitating and there is a value for this. So the evidence shows that. సో
సార్ అంటే ఇంకోటి ఏంటంటే మీకు అంటే ఇప్పుడు ప్రెసెంట్ గా మేము ఫాలో అవుతుంది ఏంటంటే పర్ డే ఒక పేషెంట్ మీద యూజ్ చేస్తే వీఆర్ ఛార్జింగ్ 250 రూపీస్. హౌ మెనీ టైమ్స్ యూ డూ, అది ఒకసారి మీరు ఇనిషియేట్ చేశారంటే యూ ఛార్జ్ 250 రూపీస్. ఇన్ దట్ వే ఇఫ్ యూ అసెస్ డైలీ మీకు 1 year లో ద ఇన్కమ్ 15 lakhs 16 lakhs అనేది మొత్తం ఖర్చు పెట్టిందంతా మీకు వచ్చేస్తుంది.
అవును, అగ్రి. కానీ ఏమవుతుందంటే మేము వి యూస్ టు ఛార్జ్ 500 రూపీస్ ఆన్ రామచంద్ర మెడికల్ కాలేజ్ ఫర్ ఎవ్రీ పేషెంట్. 25-bed ఐసీయూలో 500 రూపీస్ ఈచ్ పేషెంట్ కి ఛార్జ్ చేసేవాళ్ళం అల్ట్రాసౌండ్. సో ఆ వాల్యూస్ అనేది మేము రాసుకునే వాళ్ళం. వాట్ వి యూస్ టు రైట్ ఇన్ ఏ కేస్ షీట్. బట్ వి డోంట్.
మాది కంప్లీట్ డాక్యుమెంటేషన్ సార్. అంటే ఇన్ ద సెన్స్ మా క్రిటికల్ కేర్ నోట్స్ లోనే when you are doing an ESG we are doing it.
Same thing we used to document it. But there it was successful in Ramchandra. Why? Because most of the patients are cash patients there. Because of the low price, they come there. But most of the patients in our corporates are either insurance or a corporate patients. So they don't pay as per our notes. We have to show a valid report for them.
Yes,
check cheyandi. They won't report. They won't give that bill.
No, Satish wants to talk. Satish sir. Satish
sir, నాకు ఒక చిన్న యాజ్ పర్ ది ఎన్ఏబిహెచ్ జేసీఏ లేకపోతే హాస్పిటల్ మెడికల్ లాస్ ప్రకారం those who are handling ultrasound should have a PNDT certificate. Very very important for that.
Sir, మేము అసలు తీసుకోలేదు సార్.
Please don't ignore that. Every person who is handling ultrasound, whether you are a radiologist or not, you need to have a certification from the government authorities. DMHO నుంచి మీ దగ్గర is authorized to use ultrasound అనే లెటర్ ఉండకపోతే మటుకు పట్టుకుంటారు. చూసుకోండి.
అంటే PNDT లో మీ నేమ్ జాయిన్ అవుతుంది సార్. నాకు తెలిసి మీ నేమ్ జాయిన్ చేసే ఉంటారు. మీ అపోలోలో ఉన్నప్పుడు కానీ సిటిజన్స్ లో ఉన్నప్పుడు కానీ ప్రాబబ్లీ చేసే ఉంటారేమో అని నా డౌట్.
లేదనుకుంటున్నాను నేను. మన నేమ్ ఫామ్ సైన్ చేయలేదు కదా సార్.
ఏమో సార్, అంటే అప్పుడు ఢిల్లీలో ఉన్నప్పుడు అయితే మా పేర్లు అయితే బై డిఫాల్ట్ జాయిన్ అయిన తర్వాత ఐసీలో జాయిన్ అయిన ప్రతి ఒక్కరికి నేమ్ వెళ్ళిపోయేది.
Yes, correct. That is the way. That is it has to go. And wherever you are practicing, that should be under that DMHO's purview. వైజాగ్ లో చేస్తే వైజాగ్ డిఎంఎండ్హెచ్ఓ నుంచి లెటర్ ఉండాలి మీకు. అది అంటే ఇట్స్ ఓన్లీ సజెషన్, ప్లీజ్ అండర్స్టాండ్.
Sir, good morning,
the
sir.
most important, sir, because we scan both male and females and pregnant patients also, no?
Yes, whoever is in ultrasound should have a PNDT certificate, that particular DMHO of that district.
Sir, good morning, sir. Good morning
Yeah,
to
yeah.
all, sir.
Yeah, tell me.
Sir, Anuradha, sir.
Yes, Anuradha, please.
Sir, నా ప్రాబ్లం రెక్టిఫైడ్ చేయండి సార్. సో వెన్ఎవర్ ఐ మీన్ CTOT, ఎనీ valve cases or anything, so I'm doing TE. So in the case sheet is not mentioning TE done because it charge. Surgeon is telling don't mention TE done. But he wants post pump, he wants report and any paravalvular leak is there or not, valve functioning or not, he wants everything.
But that
But
is
he
internal
doesn't want to
problem,
enter in the
Anuradha.
case sheet.
Anuradha,
Procedure chart, sir.
it is internal problem. Actually, if you are entering in the case sheet and they want to show the report, whether surgery is done appropriately on basis of E report, it should be charged.
Yes, sir.
It should be charged, and that problem can be handled by the management, hospital management.
Yes, sir. But I am entering in the I mean intra-op chart, the pre-op findings and post-op findings
Should be
like
charged.
this.
Management has to take the decision for that.
Yes,
Madam,
sir.
whether
Sir.
charging is not the question here. Whether
Yes, sir.
you are entering in the case sheet, it's a valid document. Once it is entered into the case sheet, it is a valid document. Authenticity
Yes.
will be more. See, what we do is, for any patient coming to the ICU who is having a septic shock, we enormously use this ultrasound machine, but we charge them once in one ICU admission. It is included in the ICU charges. We don't separately mention it. ICU charges will be fixed, charges will be there. That is 13,000 rupees per bed or 16,000 rupees per bed. In that, this is included, and we justify it with maintaining a register, showing we have done these many ultrasound, this is the income we have generated, which included in the.
Yeah, that is included.
Yes.
You need not charge separately. No? That
Yes.
already they are making a hangama for they are charging more and more like that. Then how can you charge extra 1,000? Not required, I think.
సార్ అంటే సెపరేట్ ఇన్కమ్ అనేది వాళ్ళు అంత అర్థం చేసుకుంటే పర్వాలేదు. ఇఫ్ అడ్మినిస్ట్రేషన్ ఆస్ ఫర్ సెపరేట్ ఇన్కమ్ జనరేషన్ ఆర్ రెవెన్యూ జనరేషన్ అప్పుడే ప్రాబ్లం వస్తుంది. ఇప్పుడు వాళ్ళు యాక్సెప్ట్ చేశారు అనుకోండి, మనం ఇంక్లూడ్ చేసేస్తున్నామని, దేర్ ఇస్ నో ఇష్యూ ఎట్ ఆల్.
అది ఒకటి. ఫస్ట్ సార్ చెప్పినట్టు సతీష్ సార్ ఫస్ట్ PNDT సర్టిఫికెట్ నాకు ఉందా లేదని నేను చెక్ చేసుకోవాలి ఫస్ట్.
ఇంపార్టెంట్ మేడం.
చెక్ చేస్తాం సార్ సతీష్ సార్.
ఏం సార్
అది ఎట్లా చెక్ చేయాలి?
PNDT is mandatory for intensivists to do bedside ultrasound or echo.
Yes sir, అది mandatory sir. Mandatory అంటే ఇక్కడ మనకి రెగ్యులర్ చెకింగ్ లేదు కానీ బట్ ఇట్ ఈస్ ఎ mandatory thing.
సార్ ఇది మనం we have to check with DMHO, మన ఆర్గనైజేషన్ తో చెక్ చేయాలా?
Necessary to produce a certificate for that from the intensivist side.
అంటే మనకి గుర్తుందో లేదో వర్క్ షాప్ చేసేటప్పుడు కూడా మనం అల్ట్రాసౌండ్స్ వాడాము. అంటే ఏదైనా అల్ట్రాసౌండ్ మెషిన్ అని.
Sir, I think if you are putting it on paper, you should have certificate, full stop.
Exactly.
కరెక్టే.
అంటే మీరు పెట్టకుండా చేసుకున్నారు అనుకోండి, అది నో ప్రాబ్లం సార్.
అది యాక్చువల్లీ what we are using the machine in the ICU is PNDT certified on behalf of radiology department.
On behalf of radiology sir, exactly అదే చెప్తున్నాను. అంటే ఈవెన్ I do fast scans, 2D echo అది చూస్తాను, IVC చూస్తాను కానీ బట్ I don't put on paper because we are not certified for that. అంటే I mean like in the hospital we are not.
అడిగేది ఏంటంటే అది ఎలాగో PNDT certificate is there from the radiology department. Is it necessary to have a certificate from the intensive side, whether it is qualified or not?
అదే సార్, అంటే if you want to document it in case sheet like serial IVC
certificate కావాలి. ఏ certificate కావాలి దాంట్లో?
David, can I? It is not the authenticity of the person who is doing this. నువ్వు చేయగలవా లేదా అనేది అడిగి అనవసరం. So you are doing it. It is implied that you are not supposed to do obstetrical ultrasound.
కరెక్ట్.
సో అందుకోసం యువర్ ఆథరైజ్ టు హ్యాండిల్ అల్ట్రాసౌండ్ అని సర్టిఫికేట్
ఉండాలి దానికి, ఫర్ దట్ పర్పస్.
నువ్వు ఎప్పుడైతే అల్ట్రాసౌండ్ హ్యాండిల్ చేస్తున్నావో యూ షుడ్ హ్యావ్ ఎ సర్టిఫికేట్ ఫ్రమ్ DMHO అండ్ యు ఆర్ ఇన్ ద PNDT యాక్ట్.
కరెక్ట్. బట్
అది.
ఫర్ దిస్ నాట్ రిక్వైర్డ్.
విచ్ వన్?
మనం చేసేది
చెయ్యాలి. నువ్వు అల్ట్రాసౌండ్ హ్యాండిల్ చేస్తున్నావు అంతే. వాట్ ఎవర్ ద పర్పస్ యు ఆర్ హ్యాండ్లింగ్ ఇట్ ఈస్ ఇమ్మెటీరియల్.
అదే అన్న, దట్ ఈస్ PNDT సర్టిఫైడ్ బై ది రేడియాలజీ డిపార్ట్మెంట్. వాళ్ళు తెచ్చుకున్నారు ఈ మెషిన్ కి.
It is to the person, it is not to the machine.
టు ద పర్సన్.
The person who is ultrasound should have the,
to the person and to the location, sir. Rendu.
yes and yeah.
They will certify. More
Yes.
than 2 locations in a hospital, వాళ్ళు పర్మిషన్ ఇవ్వరు. సో అదే నేను చెప్తున్నాను సార్. అంటే ఇఫ్ యూ డోంట్ డాక్యుమెంట్ ఇట్, లైక్ మనం IVC చూస్తాము, ఓకే, ఫర్ అవర్ క్లినికల్ అసెస్మెంట్ అండ్ జడ్జ్మెంట్. సో యాజ్ లాంగ్ యాజ్ యూ డోంట్ డాక్యుమెంట్ దేర్ ఇస్ నో ప్రాబ్లమ్. సో ఇఫ్ యూ వాంట్ టు డాక్యుమెంట్ యూ నీడ్ టు హ్యావ్ సర్టిఫికేట్ సార్, ఫుల్ స్టాప్, అంతే. యాజ్ సింపుల్ యాజ్ దట్. అంటే అల్ట్రాసౌండ్ మీరు దీనికి వాడుతున్నారు, ఇంక దేనికి వాడుతున్నారు వాడికి తెలియదు కదా. సో అది ప్రాబ్లం వస్తుంది సార్, అంతే.
అఫీషియల్ ఇవ్వం కాబట్టి
డాక్యుమెంట్స్ పేపర్ మీరు యాజ్ లాంగ్ యాజ్ ఇట్ ఈస్ దేర్ యూ కెన్ టెల్ దట్ కార్డియాలజిస్ట్ కమ్స్ ఫర్ 2D echo, రేడియాలజిస్ట్ డస్ అల్ట్రాసౌండ్. అంటే దట్ ఈస్ ద పర్పస్ ఆఫ్ అల్ట్రాసౌండ్ బీయింగ్ దేర్ ఇన్ ICU అని చెప్పొచ్చు సార్ ఇన్స్పెక్షన్ కి వచ్చినప్పుడు. యా, యాజ్ లాంగ్ యాజ్ యూ డోంట్ పుట్ ఇట్ ఆన్ పేపర్, నో ప్రాబ్లం.
That will be given by the either radiologist or cardiologist.
అంతే
సార్.
అవునరా సార్.
డేవిడ్ గారు, అంటే అంటే మన శ్రీకాంత్ చెప్పింది మన వరకు కరెక్ట్ గానీ, ఇఫ్ యూ యూజ్ యువర్ హ్యాండ్స్ విత్ అల్ట్రాసౌండ్ యూ నీడ్ దట్ సర్టిఫికేట్ సార్, అంతే. యూ రిపోర్ట్ ఆర్ నాట్, దట్ ఈస్ రిమెటీరియల్. ఇప్పుడు సెక్స్ ఇన్ఫర్మేషన్ నువ్వు అఫీషియల్ గా రాసిస్తావేటి, ఓరల్ గా చెప్తావు కదా. అది ఎందుకనేసి మీ అంటే మామూలుగా రూల్ ప్రకారం అయితే ఇప్పుడు మన వర్క్ షాప్ లో కూడా అంతే కదా, మనం రిపోర్ట్ ఇవ్వం కదా. మీరు యూజ్ చేస్తారంటే ఇచ్చేసేయాలి అన్నమాట. అందుకని హాస్పిటల్ ఏం చేస్తారంటే యాక్చువల్గా పర్టికులర్ గాను ఒక మిషన్, ఒక రేడియాలజిస్ట్ పేరు మీద PNDT యాక్ట్ తీసుకుంటారు.
అవును,
తీసుకొని రొటేషన్ గా చూసుకుంటారు అన్నమాట అది. బట్ ఇన్ ICU లిటిల్ బిట్ కాంట్రవర్సీ, బట్ వి షుడ్ టేక్
lines and ultrasound guided nerve blocks left and right we are doing without any certificate. అంతే కదా?
అంతే సార్.
ఓకే సార్, థ్యాంక్ యూ వెరీ మచ్.
అండర్ ద టేబుల్ యూసెస్.
Okay, thanks Anna. Thank you very much Jakina for your nice presentation, non-invasive things, and have a lot of discussions on this. Anna, ఏంటన్నా
నైస్ ప్రెజెంటేషన్ Jakina గారు, షేర్ చేయండి మీ స్లైడ్స్.
Nice presentation.
Thank you.
Thank you sir.
Thank you all for your active participation.
Nice class sir.
అప్రెంటిస్ తగ్గినాయా శ్రీకాంత్?
Anna
Sir.
శ్రీకాంత్